In terms of reproductive health and rights, the arc of history in this country has, with notable fits and starts, tended towards increased access to contraception and abortion services for women. While each administration has its own take on the government's role in reproductive health, the Trump administration, bolstered by majorities in both houses of Congress, has made substantial changes to reproductive health policy in this country. How will that affect the health and well-being of American women? To discuss the issues with me today is Dr. Megan Cavanagh. Dr. Cavanagh is an internationally renowned public health scientist with a focus on reproductive health and the impacts of healthcare policy on women. She's a principal research scientist at the Guttmacher Institute, which is a research and policy organization focused on sexual and reproductive health, and is currently celebrating its 50th anniversary. Dr. Cavanagh, thanks for joining me today.
Thanks very much for having me.
And happy anniversary to the Guttmacher Institute.
Thank you very much. We're happy to still be here.
Good. So this administration has been more proactive in this area in terms of reproductive health policy, really, than we've seen in a long time. Just briefly, how would you characterize their major actions?
Well, under the current administration, I would say that we've seen sustained efforts to really reduce access to reproductive health care broadly, both here in the United States and globally. At the Guttmacher Institute, we've been tracking these efforts very closely, and we've characterized them as falling largely into 5 core areas of focus. Those 5 core areas are on the international front. I would say there's been several attempts to undermine support for global reproductive health. And one example of that is what is known as the global gag rule. And that is a rule that the current president reinstated and expanded as soon as he came into office. And what that does is it restricts funds coming from the US government to go to organizations that provide either information or abortion services. The expansion also prohibits funds from other sources to go to these services, and they have nothing to do with US government funds.
So the global gag rule, or the Mexico City rule, I think it's also known as,
yes,
is this idea that a non-governmental organization from another country can't receive any U.S. funds if any funding they receive, regardless of whether it comes from the U.S., might promote or provide access to abortion services. And that started with Reagan, I think, right?
That started with Reagan, but the expansion is that they can't receive any other sources of funding that have nothing to do with U.S. government funding to go towards either abortion services or just providing information about abortion options.
I see. So what are the other the other big buckets that we're seeing changes in?
Yeah. The second big bucket is here back in the United States. There have been several attempts to undermine access to health insurance coverage for individuals here.
Sure.
And so I'm talking both broadly, broad insurance coverage, as well as specifically around reproductive health care coverage. So, like, for example, contraceptive methods, coverage of those methods.
So we've seen that a lot, and as a physician, I'm used to prescribing contraceptive measures of various types. Most private health plans provide reasonable coverage for that. Let's talk about the public health issue here. If you limit access to insurance-based coverage for contraceptives, what's the downstream impact there? Because people say, the pill is not that expensive, right? I mean, this has been around forever. Is there really a measurable impact in terms of public health?
Well, there really is. And the important piece here is that there's no one best contraceptive method for every woman or every couple that uses contraception. Every couple decides differently based on a multitude of factors what is important to them when they choose a method. And so it's important to have the broad range of methods available to individuals. And methods can be on the cheaper side or on the more expensive side. But what, for example, private insurance coverage does and what the Affordable Care Act contraceptive coverage guarantee did is it provided coverage for the full range of options available so that people didn't have to be swayed by choice as a factor influencing what they wanted to use for their contraceptive method.
And you've conducted a lot of research actually looking at long-acting reversible contraception, things like IUDs or implantable hormone release devices. A lot of your data would suggest that these are more effective than trying to take a pill every day. I try to take a vitamin every day, and I'm not very good at it, for example.
Right, and so there's been a lot of enthusiasm, I would say, around IUDs and implants in particular, around the potential that they may have for reducing unintended pregnancy. And while these are excellent methods that many people call them set and forget, people don't have to remember to do something about them once they are inserted or implanted, there is no one best method for everybody. So it's important to have the full range of options available to individuals. And by ensuring health insurance coverage for that full range of methods, you give people that choice.
Certainly, yeah. What else are you at the Guttmacher Institute monitoring for this in this administration?
Sure. The third core area that we are tracking is around increased support and funding for non-evidence-based sexual health education programs here in the country. So in 2010, the federal government significantly reduced funding for these programs based on overwhelming scientific evidence indicating that the programs were ineffective and potentially harmful.
These non-evidence-based programs, we're talking about abstinence-only education, I assume.
Yes, these are promoting.
I don't mean to use the lay terminology.
No, they're promoting the main message about abstinence only until marriage. That's the key piece.
And the data does not support that this, reduces the rates of unintended pregnancy or sexually transmitted diseases or sexual activity at all?
In general, right.
Okay.
And so the federal government in 2010 followed the evidence to say we shouldn't be funneling funds to support these ineffective programs. However, despite a lack of data, the current administration is now reversing that and putting funds in that direction.
Okay. Keep going. You've got two more.
Okay, so the two last ones, there has been a lot of attention lately on limiting access to abortion here in this country. And that's been both at the state and federal level, but we've seen increased attention to this most recently with the nomination of Judge Brett Kavanaugh to the Supreme Court.
No relation.
President. No relation, no.
So Brett Kavanaugh has sort of, I was about to say reinvigorated this debate, but this debate seems to be perpetual. So has added a bit of fuel to the fire because we're not entirely sure where he stands in terms of Roe v. Wade. This is a contentious issue on all sides, obviously, and we may not know until this is brought to the court, assuming he's seated. But what data do we have to assess the public health impacts of changing our protections surrounding abortions? People, I'm in Connecticut here, presumably, even if Roe v. Wade were overturned, Connecticut would have its own law and you'd have a state-by-state system and people could potentially travel from state to state. Is it as disastrous for public health as some people are claiming, or is this a more abstract problem that we may have to face?
Well, I think it's fair to say that we don't yet know what Kavanaugh would do, but we do know there have been decisions he's been involved with that have blocked access to contraception and abortion. So we can hypothesize that whomever ends up on the Supreme Court will be the deciding vote in cases related to abortion access. And so we have to start considering what the healthcare landscape around abortion would look like in a world in which Roe versus Wade might be overturned. And in that situation, it would go back to the states. So as you mentioned, right now, about 57% of reproductive age women in our country live in a state that is considered either hostile or extremely hostile to abortion access. And what that means is that those states have at least 4, and sometimes many more, restrictions in place that either significantly limit access or prohibit access to abortion in varying circumstances, how someone can get an abortion, where someone can get an abortion, and potentially the limits or the hoops that one has to jump through in order to obtain those services or travel to get those services, for example. That represents about 29 states that have those hostile or extremely hostile restrictions in place, and 4 states that have what are called trigger laws. And trigger laws are states that have laws on the books that should Roe versus Wade be overturned, abortion would immediately be banned in those states. So what that ultimately means is that someone's individual access to abortion is determined by the zip code in which they live and their income.
Let's take the right to access to an abortion off the table for a minute. It's potentially a strange thing to say. Were that to happen, were there to be large swaths of the country where abortion is simply not available, what does the research suggest would be the public health impact in terms of women's health, in terms of family health, et cetera?
Well, we can look to our global reproductive health research colleagues for some evidence to point to in that area. There's been a recent study that our colleagues at the World Health Organization, in conjunction with some of my colleagues at Guttmacher, have conducted. And there's two key findings that I want to underscore that really help us to understand what might happen here in this country. So they looked broadly at access to abortion and obtaining abortion across countries and settings where abortion was either broadly legal or highly restricted or entirely illegal. And the two key findings were, one, that there was no difference in the rate of abortion between countries where abortion was more available versus highly restricted. And number two, that abortion was obtained in a much safer environment in settings where abortion was broadly available. And most commonly, abortion was obtained in more clandestine manners in settings where it was highly restricted or illegal. So there is no difference in the rate of abortion, meaning people will always have a need to have abortions available to them. They will always try and seek abortions in whatever manner is available to them. In settings where abortion is restricted, what is available to them is highly unsafe and dangerous to their health. In settings where it's not as restricted, it's available in safer settings under medical guidelines, and overwhelmingly, abortion is a very simple and safe procedure when made available.
Do you at the Guttmacher Institute consider this a public health issue or a human rights issue, or both?
We consider it absolutely both of those things.
Let's move on to the fifth area you guys are monitoring.
Sure, and that's highly related to the one we just talked about. Because as you mentioned, people have a range of feelings and thoughts about abortion, but fundamentally most people agree that we all want to reduce the need for abortion. And there's evidence to indicate the way in which you do that is you make contraception broadly available and accessible to people, and you make it high quality, and you provide the full range of services. So the way in which we have evidence to do that, the evidence that we have shows that we have made progress in this area over the past decade or so. Between 2008 and 2014, we saw substantial reductions in the unintended pregnancy rate at the national level here in the United States, as well as the abortion rate nationally. And there are several contributing factors that would be influencing why these rates have reduced. But the key driver evidence points to is increased access to and use of moderately and highly effective forms of contraception, like IUDs and implants and birth control pills and patches and rings and shots. And that leads us to that fifth core area, which is around the publicly funded family planning safety net. Now I want to pause because I want to give a little bit of history around the Title X program for those who may not know everything about it.
Yes, many of us don't.
Yes, so the Title X program is the sole federally funded program that provides family planning services to individuals who need them, and specifically and especially for those who are lowest income and adolescents.
So Planned Parenthood is coming to mind now, but Title X is more than Planned Parenthood.
Title X is way more than Planned Parenthood. So it's a program that was established in 1970 with broad bipartisan support. It was signed into law by President Nixon. And since 1970, Title X has been guided by regulations and statutes that indicate that they have to provide a broad range of services around family planning and contraception care. It has to be very high quality, and there are a range of guidelines that are being followed throughout the Title X program. The program currently has about 4,000 centers across the country in which family planning services are provided, and they provide services, the most recent data indicate, to about 4 million women, men, and adolescents across the country. That was 2016. A huge provider of Title X services, as you mentioned, is of course Planned Parenthood. And Planned Parenthood provides about 40% or so of all Title X funded services in this country. So that's a large proportion.
Yeah, absolutely. And there's been a systematic effort to defund Planned Parenthood because they are an abortion provider.
And that's where these two last kind of core areas really intersect. Planned Parenthood sits at the crosshairs of being a very large provider of abortion care, but also being an even larger provider of comprehensive family planning care and even broader health care to individuals who access those services. Now, we know that there are broad benefits that people have experienced by accessing care in these sites. We have evidence to indicate that in 2016 alone, the care that people accessed in Title X sites help them to avoid over 800,000 unintended pregnancies and almost 300,000 abortions. And without the Title X sites and the services that are available in these sites, the unintended pregnancy rate and the abortion rate would both be about 30% or so higher than they currently are. So these are critical services that are needed and used by a large proportion of the United States population.
Thank you for giving us the numbers behind that. I think it's so important in an issue that can be so emotional for people to deal with, to bring it back to what you do as a researcher, right? You look at the epidemiology, you look at what happens as we institute programs and as we potentially take programs away. So there's a lot of uncertainty, I think, still. I mean, there's been a fair amount of movement as far as the administration has gone in terms of implementing these policies, but there's a lot more that's up in the air, and the nomination of Brett Kavanaugh is perhaps the prototype of that, but there are many things that are being considered. As you look forward and as the Guttmacher Institute looks forward, what are you planning on tracking? What are the research projects, the studies that you are going to need to focus on in the coming years?
We remain committed to providing the evidence to inform well-formed policies that really help to improve the health of individuals, both here in the United States and across the country. So right now, given all of these unknowns, given these core areas that we've just talked about that seem to be really in the crosshairs of this current administration, we're committed to trying to track the impact of what these potential policies may do for individuals who need these services, individuals who rely on these services, and individuals who may need or rely on these services in the future. So we've developed several studies, both domestically and globally, that are designed and set up to go into states and countries in which we know policies are about to go into effect or have just gone into effect. And we're setting up longitudinal studies so that we can track the impact of these policies over time and how they impact the health and well-being of individuals and their families.
Dr. Kavanaugh, thanks so much for joining me and for sharing some of the science that policy decision leads to.
Thanks very much for having me, Dr. Wilson.